Hi, my name is Kevin McFarthing. I was diagnosed with Parkinson's at 4 p.m. on Monday, the 10th of December, 2012. The thing that frustrates me more than anything else about Parkinson's is it takes so bloody long to do things. Well, it takes longer to do things like getting dressed, anything which involves fine motor skills, buttons, fortunately not yet shoelaces. I can still tie shoelaces. But I think one important thing to remember about Parkinson's is if you meet one person with Parkinson's, you've met one person with Parkinson's. It's a very heterogeneous condition with, I think it's roughly 40 symptoms that are recognized, from everything from the classical tremor to seborrheic dermatitis. So it's frustrating in many different ways. There's one group of researchers that think we need to understand everything that's going on scientifically before we spend money on clinical trials which may fail. I'm an impatient patient. I can't wait. And so we need to find a way that mixes the scientific understanding with the pragmatic clinical approach to try to produce things which may not be a complete cure, but we should make our lives better on a day-to-day basis. In the same way as UPDRS ended up being the go-to measurement system for Parkinson's, which was, if I remember correctly, an international consortium of experts locked away on a Greek island and refused exit until they came up with a solution. Perhaps we need the same approach to the devices. In many respects, there comes a point when you stop trying to assess which is the best device and just choose one, because there's a law of diminishing returns, and every scientific study takes time which I can't afford. Apparently, Voltaire had a famous quote which says, "Perfect is the enemy of good." And what we need is something that works well enough, but isn't necessarily perfect, to actually get some results coming through, which will inform future development. Well, there's a very simplistic example used in the field of open innovation, which is if I have 5 ideas and you have 5 ideas and we share them, we both have 10 ideas. And that's, okay, it's a bit cliched, but it's the same with data sharing. The more data that we share, the more we all have access to this, to a greater resource. It's important that common methods are used to analyze the phenotype. There's such a variety of primary outcome measures and secondary outcome measures that it's almost impossible to compare different treatments. So commonality of outcome measures, including patient-reported outcomes, are fundamental. At the moment, a lot of what we measure is what scientists and clinicians can see. We're not very good at measuring what happens when the scientists and clinicians aren't there, what happens on a daily basis. And this is where devices come into play. We need to turn the subjective into the objective. We need to turn the qualitative into the quantitative. In business, products and services need customers. In clinical trials, you need patients. And without patients, you have nothing. When the voice of the patient is involved, and this sounds again cliched, but it's important to listen and not just hear. It's also important not to use your own selection bias to look for the answers from patients that you want. Open listening and true involvement will add value, even if it introduces some bumps on the particular road.